bring your groundbreaking research to RSNA 2024. Whether you have submitted abstracts before or this is your first time, now is a great time to show off your hard work and submit your cutting-edge research abstract. We are currently looking for abstracts focused on multi-omic and multi-center radiology AI, theranostics, low-field and mobile MRI, and value-based, equitable, and sustainable radiology. Abstracts are due August 7th, noon Central Time. Learn more at rsna.org/abstracts.
Hi everyone, welcome to the RSNA Radiographics podcast. I am Wang and I am at Mayo Clinic, Rochester. Today we'll be talking about the article Congestive Hepatopathy, Pathophysiology, Workup and Imaging Findings with Pathologic Correlation from Flory and colleagues. I personally love learning about the pathophysiology of disease because it can really help us understand disease entities and their imaging characteristics better. And pathological correlation with imaging is always the icing on the cake. So what is liver congestion and why does it matter to us? Congestive hepatopathy has been used in the literature to refer to cardiac causes of liver congestion. Hepatic venous thrombosis and sinusoidal obstruction syndrome can also result in impaired venous outflow from the liver, which causes hepatic congestion. These disease processes have a similar pattern of parenchymal injury and histopathologic sequelae and overlapping imaging features. We as radiologists are seeing more liver congestion due to patients with heart disease living longer with improved surgical techniques and medical management. What is important for the radiologist to recognize is that patients with impaired hepatic venous outflow can have hepatic lesions, which mimic standard imaging characteristics used to diagnose fibrosis and hepatocellular carcinoma. Of important note, the liver imaging reporting and data system, LIRADS algorithm, cannot be applied in these patients. So let's look at the vascular anatomy of the liver first. So we have inflow, which is a portal vein, and the hepatic artery, which supplies a total blood volume of approximately 25% of the cardiac output. The portal vein supplies approximately 75% of the blood supply to the liver in the form of partially deoxygenated, nutrient-rich blood from the GI tract, spleen, and pancreas. The hepatic artery supplies the remainder of the blood supply with oxygen-rich blood from the aorta. When there is a decrease in portal venous inflow, there is an increase in the inflow from the hepatic artery by the arterial buffer response and can compensate up to 60% decrease in portal venous flow. However, when there is decreased inflow from the hepatic artery, the portal venous system cannot compensate. Small amount of inflow to the liver are from small aberrant veins, which drains directly from adjacent vessels into the liver, which is termed the third inflow. This leads to an altered microvascular environment at these locations where the veins connect with the intrahepatic portal venules and arterioles. On imaging, we see this as variant enhancement or focal fatty sparing or deposition. Now, let's look at all of this on a microscopic level. Let's start with the basic unit of the hepatic parenchyma. It is a hexagon-shaped lobule, which includes a portal triad. So that's your hepatic artery, bile duct, and portal vein at the vertices. And then the hepatic vein is at the center of the lobule. The terminal hepatic arterioles and portal venules at the vertices flows centripetally and mixes within the hepatic sinusoids, which supplies the hepatocytes. Potentially, there are 3 communication routes between the terminal portal venules and terminal hepatic arterioles, and they play a part in maintaining perfusion to the hepatocytes. So firstly, we have transsinusoidal, and then transversal. So that's by the vasa vasorum of the portal vein, and then transplexal, so via the peribiliary plexus. Hepatocytes are arranged in cords along the sinusoids within the hepatic lobule. There are zones. So zone 1 hepatocytes are closest to the portal vein. that is most peripheral in the lobule and perform oxygen-demanding metabolic functions. And then zone 3 hepatocytes are the most central, so they're the closest to the central vein and perform functions that require less oxygen. In terms of outflow, blood flows down a pressure gradient from the sinusoids away from the liver by the central venules and hepatic veins to the inferior vena cava and then the right atrium of the heart. From a pathophysiology point of view, all of the causes of liver congestion result from impaired drainage of blood from the liver. And this can be passive and slash or obstructive. The sequelae of this is that pressure builds within the central hepatic veins and then transmits back to the hepatic sinusoids. The hepatic sinusoids do not have connective tissue, so this prolonged elevated venous and sinusoidal pressures causes perisinusoidal edema, hemorrhage, and thrombosis. Given that zone 3 hepatocytes are the closest to the central vein, they're the first to be affected. What then happens is centrilobular perisinusoidal ischemia, hepatocyte atrophy, and then fibrosis. The bridging fibrous septa, which developed between the central veins, is unique to congestive hepatopathy and not seen in non-congestive causes of cirrhosis. The fibrotic bands coalesce, dividing the parenchyma into rounded areas of relatively preserved zone 1 hepatocytes. The zone 1 nodular areas of parenchyma, which are periportal, are what we see as the regenerative nodules. The hepatic arterial system tries to compensate in the setting of impaired venous drainage and congestion by overcoming the increased pressure and resistance and thus flows better than the portal venous system. This change in inflow results in hepatic arterialization, with resultant aberrant nodular hepatocyte regeneration around these oxygen-rich areas of perfusion. These nodules are histologically very similar to focal nodular hyperplasia, FNH, and are thus termed FNH-like nodules in the setting of abnormal background liver parenchyma. There are 3 broad categories for the cause of liver congestion. These are based on the level of primary vascular impairment relative to the hepatic veins. So we have supravenous, intravenous, and infravenous. So supravenous, the causes are predominantly cardiogenic. Intravenous causes obstruction of the hepatic veins, so primarily Budd-Chiari syndrome. And then infravenous causes are those that obstruct below the level of the hepatic veins. That's at the level of the sinusoids. So sinusoidal obstruction syndrome occurs when the sinusoidal epithelial cells slough off and cause obstruction. Injury is usually due to toxic effects such as chemotherapy agents and environmental ingestion. In terms of imaging of congestion hepatopathy, this can be divided into diffuse and focal observations. So let's look at the diffuse findings first. On ultrasound, due to the elevated central venous pressure secondary to congestion, there is increased portal vein viscosity. As severity increases, there will be findings of volume overload such as ascites, gallbladder wall edema, portal venous edema, and anasarca, and you can see these on all modalities. In supravenous causes of liver congestion, there will be dilatation of the IVC and hepatic veins, and you can see that on all modalities too. Greater than 8 to 10 millimeters of the middle hepatic vein is considered to be enlarged. On spectral Doppler ultrasound, there will be aberrations in the expected triphasic hepatic venous waveform due to altered transmitted pulsatility and flow from the heart. In intra and infra hepatic venous causes of liver congestion, there is small to normal size hepatic veins and dampened hepatic venous waveforms in the affected veins on spectral Doppler ultrasound. Keep in mind that there are other entities which can lead to dampened hepatic venous waveforms, such as cirrhosis and iatrogenic altered circulations, such as Fontaine procedure. To help differentiate the cause of dampened hepatic venous waveforms, after Fontaine, the hepatic veins will be dilated. In Budd-Chiari, the hepatic vein or veins will be narrowed or absent, and in sinusoidal obstruction syndrome, the hepatic veins will be of normal caliber. There can be morphologic changes in the liver in liver congestion that overlap with fibrosis, including diffuse parenchymal coarseness, nodular contours, decreased volume, widened fissures, and hypertrophied caudate. These can be seen on ultrasound as well as other modalities. Size can help distinguish cirrhosis from nodular parenchymal regrowth, where liver enlargement is usually related to congestion and nodular regeneration, and then decreased volume is more commonly seen with true fibrosis. On CT and MRI, the most common diffuse imaging pattern of liver congestion is mosaic enhancement. In the earlier phases, there is predominantly peripheral reticular band-like areas of hypoenhancement with central sparing. With time, this equilibrates with a more uniform enhancement. For MRI, using hepatobiliary contrast, in hepatic, arterial, and portal-venous phases, there is also the mosaic modeled enhancement, just like with extracellular contrast material. However, on the 15 to 20 minutes delayed T1 hepatobiliary phase, the dilated sinusoids can be better demonstrated as hypointense areas and sharply delineated due to the lack of uptake of the hepatobiliary contrast. Now, let's look at focal observations. Firstly, we have shunts. Intrahepatic shunts can often develop in patients with liver congestion. On contrast-enhanced imaging, these are wedge-shaped, arterially enhancing areas but become iso-enhancing relative to the background liver parenchyma in all other phases and sequences. This is important to distinguish from HCC. On the delayed T1 hepatobiliary phase, these areas will retain hepatobiliary contrast and is iso-intense on T1 and DWI sequences. Next, we are going to talk about several different types of nodules that we might see in congestive hepatopathy. Firstly, we have benign regenerative nodules. These are hyperplastic growth of hepatocellular origin that occur in response to cell injury or hypoperfusion. On ultrasound, they have a variable appearance. There may be no distinguishing feature between regenerative nodules and HCC on grayscale ultrasound. Contrast-enhanced ultrasound can help distinguish the two. Just like cross-sectional imaging, regenerative nodules have arterial hypoenhancement and remains hyper or iso-enhancing on portal venous and late phase imaging. In contrast, most HCCs will show washout by portal venous phase and or by the late phase. Additionally, regenerative nodules show a homogeneous or centrifugal arterial enhancement pattern, similar to FNH-like nodules, whereas HCC nearly always shows heterogeneous arterial enhancement and does not demonstrate the centrifugal enhancement seen with FNH. It is important to know that in cross-sectional imaging, these imaging characteristics overlap with those of FNH-like nodules. Next, we have FNH-like nodules. These are very common benign nodules that develop in liver congestion due to decreased portal venous flow and increased autoregulatory hepatic arterial flow. On ultrasound, the grayscale appearance can be variable. Classically, they are described as hypoechoic. When present, the detection of a central scar and spoke wheel pattern of vessels with color Doppler can be helpful. Contrast-enhanced ultrasound can help differentiate FNH-like nodules from HCC. FNH-like nodules will show centrifugal, eccentric, or homogeneous arterial enhancement and remains hyperenhancing in the portal venous phase. This differs from HCC. One caveat in regards to this is that not much of this research has been carried out in congestive hepatopathy. Similarly, on CT and MRI, FNH-like lesions have brisk hypoenhancement on arterial phase. Classically, they're described as iso-enhancing on portal venous phase. Their enhancement post-contrast can be variable. Both FNH-like and regenerative nodules can occasionally demonstrate washout on delayed phase imaging on CT and MRI, and this feature overlaps with HCC, and distinguishing these lesions from HCC is challenging. In these cases, ancillary features in addition to time and clinical context can be useful. FNH-like nodules occasionally show mild T1 hyperintensity and mild T2 hyperintensity, so features which can overlap with those of hepatocellular adenomas and HCC. The occasional T2 hyperintense and T1 hyperintense central scar, which can appear bright on DWI, is a feature not seen with HCC or in hepatocellular adenomas, so it can be useful. MRI with hepatobiliary contrast material is very helpful in distinguishing FNH like lesions from adenomas and hepatocellular carcinomas, since FNH like nodules show increased uptake of contrast material in the hepatobiliary phase. A rare exception is well differentiated hepatocellular carcinoma and certain subtypes of hepatic cellular adenomas, which is the inflammatory and the beta catenin mutated subtypes, which may retain the ability to take up hepatobiliary contrast material. Now, let's look at pre-malignant adenomas. There are different subtypes of adenomas, with the inflammatory subtype being associated with marked sinusoidal dilatation and inflammatory cell infiltrates. On ultrasound, adenomas have a variable appearance. Small adenomas are typically isoechoic to background liver. However, if there is abnormal background liver parenchyma, these lesions can look hypoechoic. The fat-containing subtypes are usually hyperechoic. It is usually the larger, so greater than 5 centimeter adenomas, which can undergo degenerative changes, and on ultrasound, this may appear heterogeneous. Contrast-enhanced ultrasound is useful for differentiating adenomas from FNH-like lesions, but not from hepatocellular carcinomas. Adenomas show arterial hyperenhancement and are hypoenhancing in the portal venous phase and delayed phase. So this is very similar to hepatocellular carcinomas. On cross-sectional contrast-enhanced imaging using extracellular agents, adenomas are usually hyperenhancing during the arterial phase and typically do not wash out. Hepatocyte nuclear factor 1 alpha mutated adenomas are often seen in congestive hepatopathy and frequently show intralesional fat on imaging. This manifests as a signal dropout on opposed phase images. The inflammatory subtype is associated with increased signal intensity on T2 weighted images, particularly in the periphery. Adenomas are hypointense on delayed hepatobiliary phase imaging due to the lack of uptake of contrast material, with the exception of some of the inflammatory and beta catenin mutated adenomas. This feature overlaps with that of HCC, and more data on the imaging features and types of adenoma in liver congestion specifically are needed. Lastly, we will talk about hepatocellular carcinoma. This is the most concerning lesion for patients with liver congestion, and patients with liver congestion are at higher risk of developing HCC. On ultrasound, HCC is classically hypoechoic. However, there have been reports of hyperechoic HCCs for those with associated fat content. Contrast-enhanced ultrasound would demonstrate heterogeneous arterial enhancement and washout on portal venous and late phases. On CT and MRI, typically HCC will have non-rim arterial hyperenhancement with non-peripheral washout in the portal venous and delayed phases. MRI can be helpful in demonstrating ancillary features such as intermediate signal intensity on T2 weighted imaging, restricted fusion, intralesional signal loss in fat-containing HCCs, hypointensity in the hepatobiliary phase, and tumor in vein. It is important in patients with congestive hepatopathy to have correct and accurate assessment of liver fibrosis, as this impacts their management and for those being evaluated for heart transplant. Morphological signs, usually considered classic for cirrhosis, have low specificity for advanced cirrhosis in the setting of liver congestion, as these changes may result from processes other than fibrosis. Elastography in patients with liver congestion is under investigation. as both fibrosis and congestion can result in an increase in liver stiffness. Low liver stiffness measures can rule out advanced fibrosis, but elevated stiffness values should be interpreted with caution. Studies of shear wave, ultrasound elastography, and MR elastography show a statistically significant correlation between liver stiffness and the time since the Fontaine procedure. While some research shows a link between MRE stiffness and fibrosis levels, it is suggested to use higher cutoffs for diagnosing advanced fibrosis in patients who have had a Fontaine procedure. Additionally, newer studies are exploring the potential of elastography as a long-term marker for prognosis and monitoring cardiac function, and not just the degree of liver fibrosis. Liver biopsy remains the standard for the assessment of fibrosis. The standard way of measuring liver fibrosis may not be accurate for people with congested livers, as the fibrosis pattern is different. Newer systems like the Congestive Hepatic Fibrosis score and methods that directly measure the amount of collagen in the liver have been proposed to give a more accurate picture in this group of patients. Interestingly, a high level of fibrosis may not necessarily mean a higher mortality or an indication for a liver transplant in these patients. The take home message of this article is that distinguishing between benign from malignant lesions on imaging is challenging in patients with congestive hepatopathy. The major features used by CT/MR LIRADs do not have the specificity for diagnosis of HCC in patients with congestive hepatopathy. Therefore, LIRADs and organ procurement and transplantation network criteria should not be applied in this population. Management of these challenging lesions should be based on multidisciplinary discussions. Thank you for joining me today. I highly recommend you to access this article online, especially for the figures and the algorithmic approach to focal hepatic lesions in patients with congestive hepatopathy, which is proposed by the authors. Have a great day and see you next time.